Good evening. Welcome to Dysautonomia International's April webinar on Sjogren Syndrome. My name is Lauren Stiles. I am the president of Dysautonomia International. We're glad to have all of you joining us this evening. We're also pleased to be joined by Dr. Brent Goodman, who is an autonomic neurologist at the Mayo Clinic in Scottsdale, Arizona, and he's also a member of our medical advisory board here at Dysautonomia International. He graduated from medical school at Tufts University and did his training in neurology, a fellowship in clinical neurophysiology and neuromuscular medicine at the Mayo Clinic, and then he actually started the Autonomic Lab at Mayo Scottsdale. So without further ado, I'm going to turn it over to Dr. Goodman, and if you want to ask any questions, you can type in some questions into the webinar tool, and at the end of the webinar, we'll go through as many of the questions as possible. Please try not to ask personal medical questions. Dr. Goodman can't give you an office consult by webinar, but general questions about Sjogren's and dysautonomia would be fine. All right, Dr. Goodman, take it away.
All right, thank you very much, Lauren. It's great to participate in the webinar tonight. Looks like we have about 125 folks logged on so far. So what I'm going to try to do is try to tell a story. The themes of the story will be, I guess, number one, you see what you look for, which is an important lesson for those of us thinking about Sjogren's. Second, Sjogren's is hard to diagnose, extremely hard to diagnose, and we'll spend time talking about that. Third, autonomic nervous system impairment. Dysautonomia is common in Sjogren syndrome. And then fourth, and hugely important issue is, so what are we going to do about all of this? So I'll talk about the clinical features of Sjogren's, discuss how Sjogren's can affect the autonomic nervous system, and we'll discuss some treatment options, treatment approach when we think about Sjogren's affecting the autonomic nervous system. So there's a lot of dogma with respect to Sjogren's, so we have to be careful of dogma always and be open to this diagnosis, and you know, a lot of research is necessary to understand issues, particularly as they pertain to the autonomic nervous system. So I've been interested in this for a while now, and I really mean you see what you look for. It was quite literally just about 3 years ago when I had just a handful of patients that I had diagnosed with Sjogren's and an autonomic problem. These days, the last time I looked, I had approaching 60 patients, so about 3 years later. So this is a condition that the more you look for it, the more we see it as clinical providers. So what I've learned is that the autonomic nervous system is frequently affected in Sjogren's. Sjogren's is an under-recognized cause. Notice I said cause of autonomic nervous system impairment. So Sjogren's causes autonomic dysfunction. There's a spectrum, there's a range of how Sjogren's can impact the autonomic nervous system. So it can range from subclinical, sort of asymptomatic involvement that we might see only with autonomic testing, to outright autonomic failure. The diagnostic studies for Sjogren's lack sensitivity. That's a big problem. We'll be talking about that. And near and dear to my heart, there seems to be little interest in treating autonomic symptoms due to Sjogren's with immunotherapy. So I hear a lot of things, have heard a lot of things over the years, so I'm always cautious in accepting dogma, but some of the things that I hear include, I wouldn't recommend further testing for Sjogren's because it wouldn't change management. I've occasionally heard immunotherapy has not been proven to help small fiber neuropathy, GI dysmotility, autonomic neuropathy related to Sjogren's. I've heard, and you read in articles, autonomic dysfunction in Sjogren's is typically mild. Or I've heard from many rheumatologists and patients who we co-manage that those symptoms don't result from Sjogren syndrome. There's also been a general acceptance, general idea over the years that autonomic failure in Sjogren's patients occurs only in those with a significant sensory neuropathy or a sensory ganglionopathy. So we'll be talking about these things. So just so that we're all on the same page with respect to nomenclature, I always like to make sure that language is precise as possible, because that's important when we talk about conditions that affect the autonomic nervous system. And, as neurologists, we try to be as precise as possible with our language. So first of all, POTS, as probably most on the webinar know, is characterized by a certain set of criteria that include individuals must have postural symptoms. We must see an increase in heart rate, 30 beats per minute in adults, or a heart rate greater than 120, and that's within 10 minutes of standing or tilt. And then we do not typically see orthostatic hypotension or conditions that may cause orthostatic hypotension in POTS patients. So those are the established criteria for POTS. And I just have a couple of studies to demonstrate what we look for, what we see in a POTS patient. So this is a fairly typical study that we might see with heart rate in green. And I don't know if you can see my cursor, but you see that green arrow there where my cursor is. And that's where the tilt table is being tilted up, and we see an increase in heart rate, in this case, that goes up above or around 150 beats per minute. So a huge increase in heart rate. The other thing that we look for is blood pressure fluctuates a lot. So you can see these fluctuations, or what we call oscillations in blood pressure, when we tilt the table up. So that's typical in a patient with POTS. So I hear a lot about hyperadrenergic POTS. Of course, we read about it. So this is what it can look like. So this is a patient of ours who, again, underwent the tilt table study. The tilt up is with the green line here, and you see in this case, there's not only an increase in heart rate, but a really significant increase in blood pressure in this patient. And so that's what we can see in someone who's hyperadrenergic. This is best appreciated in the middle column here, where this is a blood pressure, systolic and diastolic, so pulse pressure. And you can see, again, an increase in blood pressure with the tilt table being tilted up. And down below, another patient who has both an increase in blood pressure and heart rate. So that's what we can see with hyperadrenergic POTS. That's one of the things that we're looking for. There's also another form of POTS that's been described, and this case, just hot off the presses, I put this slide in there today. A patient who went through our lab earlier today, who again has a significant increase in heart rate, approaches or reaches 150 beats per minute with tilt. But the other thing we see is down here on the bottom is the patient isn't sweating. So there was zero sweat output in the forearm, and the patient didn't sweat in the foot, which is in yellow. The leg, upper leg and lower leg is in blue and green, and there's some sweating there. So this is a neuropathic form of POTS where sweating is impaired, and so that indicates that the autonomic nerves that are going to sweat glands are dysfunctional, and so this is a neuropathic form of POTS. So in terms of dysautonomia, I think this is more of a general term that can include POTS, but is not limited to that. So this can include patients with autonomic neuropathy, GI dysmotility, a sweating disorder, or a genitourinary problem. So I'll use this term when I'm not sure, does somebody have an autonomic neuropathy or do they have POTS? And before we do the testing, as we're trying to figure these things out and try to define what a person has. In autonomic neuropathy, refers to a condition affecting the autonomic nerves, which go to blood vessels, sweat glands, involved in GI system and bladder function, amongst other things, but those are the primary areas that we're looking at. And this is an example of a patient with an autonomic neuropathy, so very different from POTS. We see here that when we tilt the table up, the tilt table testing shows a drop in blood pressure, orthostatic hypotension. You can see the heart rate doesn't budge at all, so very distinct from a POTS patient where the heart rate would increase a bunch. So this is orthostatic hypotension. The other feature that we can see is that the heart rate doesn't vary as much as it should when the person is doing deep breathing. So when we breathe in and out, heart rate is varying with that, increases with inhalation, decreases with exhalation, and we see that there's reduced variability, and that's typical of an autonomic neuropathy. Here is an example in the same patient, and I like this case because we see this in red is the forearm, which is sweating too much. This is compensatory hyperhidrosis, sweating too much, because this person is sweating too little in the foot, which is in yellow. So this is a form of autonomic neuropathy. So that's what autonomic testing can look like in an autonomic neuropathy. This is orthostatic hypotension, so defined as a drop in blood pressure that's sustained greater than 20 millimeters of mercury systolic. This was a case that we had in our lab recently, and just it's an amazing picture where you see the blood pressure just plummets. And this was one of the lowest blood pressures ever recorded in our lab. Amazingly, the patient was able to maintain consciousness with a blood pressure of 44/30. So that's pretty remarkable not to pass out with that blood pressure. So that's orthostatic hypotension, and very different from POTS. GI dysmotility. So in autonomic disorders, an area that, in my opinion, not enough attention is paid to, including in dysautonomia and in POTS, the esophagus, the stomach, the large and small bowel may develop a motility problem. The motility problem may be too rapid, and rapid gastric motility has been reported in POTS patients and is actually reported to be the most common abnormality when one undergoes formal motility testing. Or each of these areas may have a motility problem that results from delayed transit. And so this happens in POTS, and I do think it's important for particularly us as providers to recognize that GI dysmotility, esophageal dysmotility, is actually a form of autonomic failure. We're working on something now where we're looking at our patients who we've diagnosed with POTS who have feeding tubes, and this is just part of a table, but we actually have 32 patients in one of our series who actually have feeding tubes, and most of those patients have gastroparesis. So again, this is a form of autonomic failure. It can be bad. So the other things to think about when we think about language and Sjogren's and autonomic problems is when we're looking at an autonomic disorder, we try to determine whether there's an underlying cause or not. So one of the terms that we use in neurology is secondary, a secondary cause for something. So for example, if someone comes to me as a neurologist with a headache, one of my jobs is to determine whether there's a secondary cause for the headache. So I have to quickly figure out, do I need to think about a brain tumor? Do I need to think about meningitis or an infectious process? Do I need to think about increased intracranial pressure or a CSF leak? Various things. These are secondary causes of headache. Or is this a primary headache condition? Is this migraine or tension type headache without any other distinct secondary or underlying cause? We should be doing that when we approach a person with a suspected autonomic disorder. And in my opinion, when we make a diagnosis of POTS, we should try to be as precise as possible in saying this is a post-infectious form of POTS, or this is a post-concussive form of POTS, or this is POTS with Sjogren Syndrome, topic of this talk. So this is an example of this where a patient I saw a number of years ago, actually one of the first patients I used IVIG on, who actually turned out to have Sjogren Syndrome. Ultimately, she was 16 when we first saw her, and she had POTS and what we as neurologists called new daily persistent headache following an upper respiratory tract infection, so post-infectious form of POTS. And this is what her autonomic testing looked like first go around. So a very excessive heart rate increase. You see a collapse in her pulse pressure, very unstable blood pressures. And then 4 years later, this is her autonomic testing looking very different. She's much better now, but not normal from an autonomic perspective. So again, post-infectious POTS that ultimately we thought was autoimmune with sort of chronic ongoing symptoms, but also demonstrating that the autonomic nervous system does change over time. This is an example of POTS following a traumatic brain injury. So post-concussive POTS, this was a professional hockey player who was involved in multiple fights and came through our clinic. And the brain MRI down below is actually abnormal, showing, if you look closely, there are little, what we call hyperintensities on the MRI scan that were thought to result from his brain injury. And you can see on the tilt table testing, this is a very, very abnormal profile showing very unstable blood pressures and an excessive heart rate increase. So this is POTS following traumatic brain injury. So there already is considerable evidence that POTS is probably an autoimmune condition or begins as an autoimmune condition in a lot of people. So this was a report of really what the first descriptions of POTS in the time of the Civil War in this soldier who developed what we would now call POTS following a diarrheal illness, probably a gastroenteritis of some sort. And then in this 1918 report of what they called irritable heart, but what we now call POTS or dysautonomia, 30% of cases had a preceding infection. And it's likely in those cases where POTS begins following an infection that the POTS in and of itself begins as an autoimmune condition. I had this patient several years ago who had the onset of a number of symptoms, including kind of neuropathic type pain across the thorax and autonomic symptoms. She was actually from South Africa, flew all the way here. She was a sister of a neighbor and friend, and her symptoms began 7 days after miscarriage and infection. And she came from airport from South Africa right into our hospital. She got worked up in hospital. Of course, symptoms began after a miscarriage, so everyone assumed that this was psychological. So she was evaluated in our clinic, and ultimately we diagnosed her with what looked like POTS on autonomic testing, again, very acute, within 3 to 4 weeks of symptom onset. And ultimately, I thought it was worthwhile to treat her aggressively with immune therapy, and her autonomic testing improved dramatically with immune therapy. So to me, this was evidence in favor of POTS being post-infectious and being potentially autoimmune, and us treating within this window where the immune system might be still active and causing problems. So here's another example of the autonomic nervous system becoming abnormal acutely. So this was a woman who was referred in for whole body numbness and profound syncope and near syncope. She came to clinic in a wheelchair, and again, her symptoms began in a post-infectious pattern very acutely. and she had been diagnosed with orthostatic hypotension prior to coming to our clinic. Here's her tilt table testing, which showed profound orthostatic hypotension. So you can see a severe drop in blood pressure without a good increase or appropriate increase in heart rate, and she didn't sweat at all. So this was an autonomic neuropathy with orthostatic hypotension, so not POTS, but we worked her up, and her laboratory studies suggested that she had Sjogren Syndrome. So in this case, this was how she presented with Sjogren Syndrome, acutely, fulminantly following an infection. So Sjogren Syndrome can cause autonomic failure. It can begin acutely. It can begin in a post-infectious pattern. This was another case that we saw not all that long ago, who was referred in for numbness, weakness, and syncope, and again followed an infection. And she reported a number of symptoms, including really a lot of GI symptoms. She did not have dry eyes and dry mouth. She had been diagnosed at an outside hospital with Guillain-Barré syndrome, a diagnosis that we didn't agree with. She had orthostatic hypotension and some sensory loss on exam, so we thought she had a neuropathy and autonomic dysfunction. And her autonomic testing looked completely terrible. Down below, hopefully you can see my cursor, she had horrible orthostatic hypotension. She didn't last long on the tilt table at all. We had to tilt her back very quickly. And an interesting pattern of sweating in that she did not sweat in her arm, leg, but she sweated in her foot. And so that's what we call a non-length dependent pattern of neuropathy. And that's typical of what we can see with Sjogren's. And so in spite of her not having dry eyes and dry mouth, we did a minor salivary gland biopsy, and that showed evidence of Sjogren syndrome. So again, Sjogren syndrome can begin very fulminantly. It can begin following an infection. It can present as autonomic failure or primarily with autonomic symptoms. So just some general considerations about Sjogren syndrome. So this is under-recognized for sure, affects at least, people have suggested, 3.1 million Americans. And Sjogren's has been reported to primarily affect the lacrimal and the salivary glands. So it often presents with dry eyes and dry mouth, and that's one of the clinical features of the conditions. But it can affect the extraglandular tissues, so tissues outside of the lacrimal glands and the salivary glands, and it can cause neurological problems, pulmonary conditions, GI symptoms, and autonomic symptoms are actually quite common in Sjogren syndrome. So I borrowed this from the Sjogren Syndrome Foundation. I hope they don't mind, but I thought it was a nice picture demonstrating all of the different areas that can be affected by Sjogren's. I guess one critique, I would have kept the esophagus pink along with the rest of the GI tract, because I do think the esophagus is frequently involved in patients who have GI symptoms with Sjogren's. So Sjogren's can affect the bodily systems in a number of different ways, and not just autonomic. Sjogren syndrome has a strong female propensity. It's been suggested to range from 9 to 20 to 1. Seems to be more prevalent in Caucasian women. Mean onset is in the 4th to 5th decade. And prevalence rates actually can be pretty high in the elderly. I have recently made this diagnosis in 60s and 70-year-olds. So this is a condition that can, I don't know if begin is the right word, but certainly become more prominent. People can develop more prominent symptoms at any point during one's lifespan. It's been suggested that Sjogren's is uncommon in children, and there actually aren't a ton of reports in the literature of Sjogren's in pediatric population. But I can say I've definitely seen it in teenagers, but certainly it's a condition where we're more likely to diagnose this in 30s, 40s, certainly. Prevalence, this is a table of prevalence rates in different populations, and you can see here on the column to the right, the prevalence rates are all over the place, and upwards of 2% of the population. So some of this variability in prevalence has to do with how Sjogren's gets diagnosed, what the diagnostic criteria are, but certainly it's possible that there are some ethnicity differences with respect to Sjogren's patients. But this is for reasons that will become clear when we talk about diagnosis. It's difficult to really get a good population-based study to determine accurately the prevalence of Sjogren's in a population. So how do you diagnose this? Ideally, most patients would have dry eyes and dry mouth, but as I'll be discussing in neurology with neurological complications of Sjogren's, the dry eyes and the dry mouth may not predate the neurological symptoms. So that complicates things, but that's, at least historically, those are symptoms that we're looking for. And then we look for autoantibodies, primarily to SSA, and then minor salivary gland biopsy is another tool to try and establish a diagnosis of Sjogren's. So there are diagnostic criteria for Sjogren's that have been established. This is one of them, most recently published. These diagnostic criteria, they're actually intended for clinical trials. So these are actually not so much intended for day-to-day clinical use, but for, considering whether a person should be entered into a clinical trial for Sjogren syndrome. But you can see here that these diagnostic criteria basically gives a score to what firstly is minor salivary gland biopsy abnormality consistent with Sjogren's or meeting criteria for Sjogren's, and then antibodies, and then objective testing for dry eyes and dry mouth. So these are all obviously objective tests for dry eyes, dry mouth, the antibodies, the SSA antibodies, and then minor salivary gland biopsy. So those are the diagnostic criteria. Again, this criteria is actually, its purpose is more for use in clinical trials. So important to recognize, and there's a lot of confusion about this, I think. Other antibodies occur in patients with Sjogren syndrome. SSA is most commonly seen, and in patients with sort of classic Sjogren's with dry eyes, dry mouth, and sort of classic complications related to Sjogren's, this is the most likely antibody that one will see. SSB is less commonly seen, and with this most recent criteria, it was suggested that this is a less important antibody in making a diagnosis of Sjogren's. So RF, or rheumatoid factor, is seen not uncommonly in patients with Sjogren's. Anti-CCP antibody also can be seen in Sjogren's and can be a marker for arthritis. Anti-mitochondrial antibodies have been reported. And then this other antibody that I think I'll talk a little bit on a bit later is a muscarinic antibody that has been reported to be abnormal in patients with Sjogren's. I'll talk about the novel Sjögren antibody panel in a moment. But important to recognize that other antibodies, in addition to those, can be seen in Sjogren syndrome. So cryoglobulins can be seen. Antiphospholipid antibodies, so those have been reported in upwards of 13% of patients. Now, most patients with Sjogren's and antiphospholipid antibodies don't meet criteria for the antiphospholipid antibody syndrome, but they may have these antibodies. And again, the antimitochondrial antibodies can be seen. There are what has been called the novel antibodies for Sjogren's, and this isn't intended to be a complete list, but this is some of the antibodies that are being looked at. And one panel of antibodies are the SJO panel, and these include the salivary gland protein 1, carbonic anhydrase 6, and parotid secretory proteins. So these are novel Sjogren's antibodies that are available through the Bosch laboratories. So it's been suggested that patients with Sjogren's, that these antibodies may be more likely to be abnormal, particularly in patients who have sort of classic Sjogren's with Sika type symptoms, and that these antibodies may be more sensitive than SSA and SSB, the more sort of traditional antibodies that are used in the diagnostic criteria for Sjogren's. So I sort of use these antibodies as a kind of an adjunctive tool. I don't, at this point, for me personally, I don't feel comfortable in making a diagnosis of Sjogren's based upon these antibodies. At this point, in my opinion, and in the opinion of our laboratory people, there's not enough data to justify them being used for establishing a diagnosis of Sjogren syndrome. So we need more patients, more Sjogren's patients, and more controls before that becomes ready for prime time use for definitive diagnosis, in my opinion. There are other antibodies being looked at, including this TRIM38 and something called antiproteasome activator. So much more work needs to be done on the antibodies. I'll talk a little bit about antibodies a little bit later on, but I want to change gears and talk about neurology and Sjogren syndrome. So peripheral neuropathy is common in Sjogren's. So in this large cohort of over 1,000 patients, so an amazing study, 11% of patients in this Sjogren's cohort had peripheral neuropathy. And important for us as neurologists to recognize that any type of peripheral neuropathy that one can imagine can occur in Sjogren syndrome. In fact, I would even go further and say, I discuss with our residents that about any neurological complication that you can imagine can occur in Sjogren syndrome. And that's particularly true in the peripheral nervous system. And so autonomic neuropathy occurs in Sjogren syndrome, and we'll be talking about that shortly. This was I think, a really important study that doesn't get enough attention. So this comes from the Mayo Clinic in Rochester. And this describes a cohort of patients who have Sjogren syndrome and what primarily was a sensory neuropathy. It's a really important study because what it demonstrates is that peripheral neuropathy, number one, occurs in Sjogren syndrome. We know that. But while dry eyes and dry mouth, which we're calling SICA, dry eyes and dry mouth, occurred in 93% of these 54 patients with Sjogren's and neuropathy, that the dry eyes and dry mouth were the initial symptoms in just a small fraction of those 54 patients. Furthermore, the dry eyes and dry mouth was actually quite mild in this group. So what that means is that we actually can't in neurology use dry eyes and dry mouth as being an indicator as to whether a person or whether Sjogren's is the cause of a neuropathy. So we have to have our antenna up for Sjogren's causing a neuropathy. So the dry eyes and dry mouth, it often antedated the neuropathy developing. The other important aspect of this study was that in this group of patients, those antibodies, so in their study it was ENA, which in our labs gets sort of subtyped if it's abnormal into SSA and SSB. It was abnormal in only 10% of these patients. So the antibodies have horrible sensitivity in allowing us to establish Sjogren's as a cause of neuropathy. So minor salivary gland biopsy was done in 33 of these patients and was abnormal in just about 3/4. So minor salivary gland biopsy was not perfect either. So more about the dry eyes and dry mouth, because I do think it's an important point. So in 12 of the 54, the dry eyes and dry mouth preceded the neuropathy. The neuropathy preceded the dry eyes and dry mouth in just as many patients, simultaneously in 5. And in the rest, patients had such mild dry eyes and dry mouth that they didn't actually know when it started. So this just goes through the different forms of neuropathy from these patients. And again, I just really wanted to point out that about any kind of neuropathy that you can imagine can occur in Sjogren syndrome, but they had one patient here that they described as having an autonomic neuropathy. In that patient, the antibodies were in fact negative. So they reported autonomic findings in that series, actually. It was a small part of the study, but in this series, now again, this was a carefully selected series of patients with peripheral neuropathy who they diagnosed as having Sjogren's. The autonomic impairment was symptomatic in only one patient. So it was largely subclinical or asymptomatic, but they found a lot of abnormalities on autonomic testing. This is a classic paper on peripheral neurological manifestations in Sjogren syndrome. I love this paper. It's in one of our major journals in neurology and brain. And this fantastic paper from Japan demonstrated that autonomic dysfunction actually is quite common in patients with neuropathy, and that again, about any type of neuropathy can be seen in patients with Sjogren syndrome. Now, autonomic failure, they reported, so this is orthostatic hypotension, where patients have their autonomic system is failing, is most likely to occur in patients with severe sensory loss. But what I wanted to demonstrate here is that autonomic symptoms, so symptoms of autonomic dysfunction, occurred in any type of neuropathy in these Sjogren's patients. So it wasn't just patients with a particular type of neuropathy, but autonomic dysfunction could occur in any type of neuropathy. And I love these pictures here, and I'll just quickly go through them. This in E here is is actually a root, a sensory root, and these circles are neurons that are decreased in number relative to control. So F is a control, E is a patient, or the patient here. And so you can see that the neurons were reduced in number. H is the dorsal root ganglion. So this is a ganglion cell. And these are neurons in a normal control. You see all of these purple areas. Those are all cells. And here in the patient, they're reduced in number. So basically, what Sjogren's can do is it can take out neurons in the sensory ganglia, which are the cell bodies for the neurons. And then this down below is the patient demonstrating areas where he didn't sweat. So that's a sensory neuropathy with definite autonomic involvement due to a loss of neurons from Sjogren's. This was an editorial that accompanied that paper in Brain, and this actually was from Mayo, from Dr. Peter Dick at Mayo, and this demonstrates, I think, beautiful pictures, but really what it demonstrates is heterogeneity in how sweating in someone with Sjogren's and autonomic dysfunction can be variable. So this was a patient with normal sweating. So when you sweat, you turn purple. So this patient sweated normally. This patient here had areas where they didn't sweat. This patient here had large areas where they didn't sweat. So you can see that the autonomic impairment in these different patients was variable, heterogeneous in this group of patients. In this same paper, Dr. Dick, again, a neurologist from Mayo Rochester, still working, is suggested that the salivary, the lacrimal gland and the salivary abnormalities are not likely related at all to what's causing the neuropathy in these patients, and that we should consider that the sensory and the autonomic neuropathy occurring in Sjogren's may in and of itself reflect an immune response, sort of independent of what's happening with the lacrimal gland, with the salivary glands. This paper reported that patients actually improved with immune treatment. And Dr. Dick makes an important point in this editorial suggesting that this is a very heterogeneous condition. It's a condition that waxes and wanes over time. And so we need to take this into consideration when treating patients and when designing clinical trials. So another way to look at autonomic impairment in Sjogren's is to say, okay, if we have X number of patients with Sjogren's, we have, let's say, a Sjogren's clinic, what does autonomic testing look like in a bunch of Sjogren's patients, whether they have autonomic symptoms or not? And so this was a study out of Korea showing significant abnormalities on autonomic testing in just a cohort of patients with Sjogren's, again, not chosen because they have autonomic signs and symptoms. Another cohort of patients with Sjogren syndrome identified autonomic symptoms in about half of patients and abnormal autonomic testing in the majority of patients. Again, so suggesting in just a cohort of patients with Sjogren's that autonomic signs and symptoms are common. Another cohort of 51 patients found that autonomic testing was abnormal in most of these patients with Sjogren's. So again, autonomic testing quite frequently abnormal in patients, regardless as to whether clinically they're recognized to have an autonomic disorder or not. This, I think, was an important study which looked at, there's a cross-sectional study of Sjogren's patients looking at the compass. So this is a composite autonomic symptom scaling scoring record. So to define how significant a person's autonomic symptoms are. And they found that that patients with Sjogren's had significantly higher compass scores in this large cohort relative to controls, and that their autonomic symptoms actually correlated with measures of Sjogren's disease activity. So autonomic symptoms are not only common, but they seem to correlate with the severity or activity of Sjogren syndrome. This was a study that we did where we looked at autonomic findings in Sjogren syndrome. So we reported that not only autonomic neuropathy occurs in Sjogren's, but we see POTS in patients who we diagnose with, or we see Sjogren's in patients who we diagnose as having POTS as well, and sort of reviewed the findings in these patients. I would just highlight that GI symptoms were very common in this cohort of patients, maybe more common than in our wider cohort of POTS patients. I reviewed in this study the different findings and how we treated patients when we used immune therapy, and importantly, some of the findings on GI motility testing in patients who underwent testing here. Not all patients did, unfortunately, but GI dysmotility, again, seems to be something that occurs in patients with Sjogren's. At this point, I have a fair number of patients who we've diagnosed as having Sjogren's and POTS both, and so we have a study that's under review currently for publication, but some of the patients have findings suggestive of a neuropathic form of POTS. So that form that I mentioned earlier, where we may see diminished sweating. But the other interesting thing that I noted in this cohort of patients is that some of the patients had both hypertensive and tachycardic response on tilt table testing, in addition to a neuropathic form, so both hyperadrenergic and neuropathic. And so I've become a bit concerned that that may be a marker for patients who might be at risk for having Sjogren syndrome. So I know one of the questions that might come up is, when do you consider a minor salivary gland biopsy? And you have POTS or been diagnosed with dysautonomia. Should I have a minor salivary gland biopsy? It's a little bit invasive. The bottom line is I really don't know. I wish I did, but I certainly consider it and discuss that with my patients, that in folks who have chronic and refractory symptoms, I've maybe thrown the entire kitchen sink, so to speak, from a pharmacologic standpoint to try to help people get better, and I'm failing miserably. Patients are doing everything that they can from a lifestyle perspective, but yet aren't improving. I would consider a minor salivary gland biopsy in that situation, particularly when there's dry eyes and dry mouth. If a person has evidence of autonomic neuropathy with chronic and refractory symptoms and you don't have a good explanation for that autonomic neuropathy, I would definitely consider it in that situation. If a person has GI dysmotility, that's significant. Again, in my opinion, that's a form of autonomic failure. A minor salivary gland biopsy should be considered. If I have someone who has a family history of Sjogren syndrome, I will definitely consider it. And in our patients who we think are both hyperadrenergic and neuropathic, I will definitely consider it. The other interesting thing that to me that I think really justifies study and research is that in the patients that I see with Sjogren's who look like they have POTS, almost universally all of them have symptoms that suggest what's been called mast cell activation. I don't know why this is. I think it's probably important from a pathogenic standpoint. So I treat mast cell symptoms very aggressively in our patients who we've diagnosed as having Sjogren's. So that's a bit about autonomic dysfunction and Sjogren's and sort of what we've seen. So why is this happening? Why Sjogren's? Why autonomic involvement? What's happening with Sjogren's? What's the pathogenesis? And this is very poorly understood. Probably there's a genetic predisposition to Sjogren's. That certainly seems to be the case. It seems, in my experience at least, and those that I see, that there is a family history oftentimes of Sjogren's. But there is likely a trigger, some type of exogenous factors. I don't think it's an accident that the lacrimal and the salivary glands, which are exposed to the environment, right? Your eyes and your mouth are exposed to the environment, that they're probably exposed to exogenous factors that sort of set off this immune response and probably perpetuate it and sort of create this autoimmune soup of cytokines, and that results in activation of B and T cells in patients with Sjogren's. But a lot more needs to be understood. One of the big questions I have is, are there antibodies that are formed against the lacrimal or the salivary glands that then cross-react with nerves and sort of drive a neuropathy or autonomic dysfunction? Don't know that. We would like to know that, certainly. So what about treatment? Because pathophysiology is not well understood, treatment is certainly suboptimal. There have been a number of different approaches suggested. I think it is important to recognize that none of the medications that we use to impact the immune system in Sjogren's were developed for Sjogren's. So that's kind of that's a problem for sure. So what I do, I think it's important to stabilize the autonomic nervous system through diet, lifestyle, pharmacotherapy. I don't think it's good for the immune system to have the autonomic nervous system being unstable. I am concerned that drives autoimmune stuff. So I don't think that's good. So we always try to stabilize the autonomic nervous system as best we can. I do think it's important to stabilize mast cell pathways. And then we consider immune therapy in those who continue to have refractory signs and symptoms. And the things that I discuss with patients is Plaquenil, methylprednisolone pulse therapy. So Plaquenil, typically an oral daily, usually twice daily medication. Methylprednisolone, what I'll do is usually use that once or to twice a month IV. Sometimes that can kind of stabilize the autonomic nervous or the immune system a bit. IVIG or subcutaneous immune globulin can be considered. And in my experience with autonomic impairment, works the best in, again, my anecdotal experience. And then rituximab can certainly be considered. We reported 4 patients, and to be quite honest, I reported this just so that I could try to get some evidence into the literature to argue with the insurance companies. And this was 4 patients with Sjogren's who we treated with IVIG. And there was not only subjective improvement, but autonomic testing improved considerably on these different treatment regimens with IVIG and in one case, rituximab. So I'll try to wrap up here. I don't have much time left, but so important things to just mention. Again, dry eyes and dry mouth may develop after neuropathic and autonomic symptoms occur. So they cannot be used to determine whether somebody has Sjogren's or not in our experience, and that's established in the literature. Laboratory studies are insensitive, particularly early in the course. I repeat the Sjogren's antibody panel. Sometimes we've had patients where they convert 5-6 years after we first started testing. I have a low threshold now for a minor salivary gland biopsy, and in my experience, I have growing anecdotal evidence that autonomic signs and symptoms are immunoresponsive. I think with that, because I'm running out of time, I'll stop and happy to try and answer questions.
All right. Thank you so much, Dr. Goodman. That was really, really incredible. And I have, as many of our listeners probably know, I have POTS secondary to Sjogren's, initially set off by concussion. And I really thought I had read so much of what's out there already, but I actually learned some stuff tonight. So I very much appreciate your time and talents in helping educate all of us. So just if we can do questions for maybe 10 minutes, does that work?
Sure.
Okay. All right. So lots of questions. I definitely can't get to all of them, but I'm trying to pick the ones that I think the largest numbers of people might be interested in. So do you see Ehlers-Danlos syndrome in some of your dysautonomia Sjogren's patients?
Yeah, so absolutely. You know, I would say that definitely happens. My personal view at this point in time on hypermobility and Ehlers-Danlos syndrome is it increases the vulnerability of the autonomic nervous system to developing autonomic problems. And I also think that a vulnerable autonomic nervous system makes our immune system vulnerable to autoimmune disease. So the answer is absolutely yes.
Okay. So if someone has sort of all of the signs and symptoms pointing at Sjogren's, but their blood work is negative and their lip biopsy focal score is like a 0.8 rather than a 1, which is a positive, right? Do you ever repeat the biopsy on a patient like that, like a year down the road, or how long would you wait if you were going to repeat?
Yeah, that's a good question. I at this point have not repeated the minor salivary gland biopsy. I typically, if there's significant inflammation, even if they don't quite reach the focus score of 1, which is sort of the cutoff, I will treat empirically as if this is Sjogren's, even if I can't definitively prove that. But I will repeat the antibodies ongoing. And you will see antibodies come back abnormal if you repeat. And, you know, that occurs in other conditions as well. It occurs in, say, myasthenia gravis, which is our best understood autoimmune condition in neurology. So there's definitely value in repeating the blood tests. I really struggle with when to do the minor salivary gland biopsy. You know, it's invasive. You know, it's not something that you can repeat a ton, but I think I would potentially consider repeating it again if it was borderline at one point, but I don't know about the timing on that. But It's obviously not a perfect test. You know, it's the brain article that I presented. You know, the salivary gland biopsy wasn't abnormal in all of those cases. And in the paper out of Mayo Rochester on neuropathy, it was abnormal in less than, what was it, 73% were abnormal. So it's not perfect.
Right. I just want to add a little tidbit here that I find really fascinating. Minor salivary glands biopsies in Sjogren's patients are more likely to be negative when the patient has a history of cigarette smoking. And that, as I'm sure you can explain to everybody, is due to the nicotine in cigarettes, strangely provides somewhat of a protective benefit against rheumatoid arthritis and Sjogren's. Not that anyone's recommending smoking, but that's a complex autonomic nervous system pathway that regulates the immune system. So if you've been a smoker and you have a close to positive but not entirely positive biopsy, I would talk to your doctor about that and find the journal articles on it. Here's a question. If someone is sort of an ideal candidate for IVIG in Sjogren's with lots of dysautonomia and neuropathy, and they have Leiden factor 5, would you consider IVIG in that patient, or is that just like an absolute no-no?
Yes, that's a good question. So the consideration there is IVIG. One of the potential side effects is that a person can get a blood clot or be susceptible to blood clots when on IVIG. So that's always a consideration. What I consider in that situation is if a person does have factor V Leiden and has had a blood clot, they should be on blood thinner. And if they're on blood thinner, then they can be on IVIG. If a person has factor V Leiden and haven't had a blood clot, I'm not sure how they would know they have factor V Leiden unless there's a family history, I guess. But so we don't let a history of blood clots stop us from using IVIG. But we'll make sure, typically I'll send people to hematology and make sure, they're on anticoagulant to cover them for that increased risk of clot.
Okay. The next question is, can Sjogren's cause retinopathy?
Can Sjogren's cause retinopathy?
I think yes, but
that's a good question. I think it's been reported, but I don't know much about that.
Okay. Can Sjogren's be associated with gallbladder dysfunction?
Good question. Probably. I don't know the answer to that. I'm sorry.
Okay.
Tough question.
Sorry. How about this is a pretty tough question for everybody. If you have a Sjogren's rheumatologist, but this rheumatologist, as they often don't want to deal with neurological problems, this rheumatologist is ignoring the dysautonomia and some other neurological stuff. Are there certain types of neurologists that a patient should try to find that might be more Sjogren's savvy than other types of neurologists?
I would say the best luck would typically be someone who's neuromuscular trained and hopefully familiar with the neuromuscular literature in Sjogren's. That would typically be the best bet. And obviously, if one can find an autonomic person, that might be good too, but there aren't very many of those. So many more neuromuscular people. But, most neuromuscular doctors are comfortable prescribing immune therapy.
Speaking of which, here's a good question. If someone is prescribed high-dose immunoglobulin for Sjogren's, is there sort of a limit on how long you can receive that for? Is it it's like a term limit on the use of IVIG, or is it indefinite?
your insurance company would like for you to think that there's a term limit on your IVIG, but there is not. So
Okay.
that can be indefinite.
When you have someone that has mast cell activation syndrome, what are the common treatments you would use for those types of patients?
So I get, before I talk about that, I would just briefly say, in my opinion, a lot of what we think of as mast cell problems, I'm not 100% sure what's going on with mast cells, to be quite honest, um, but I think it's important to recognize because it is amenable to treatment. But in many patients, I sort of view it as a downstream problem. Um, so, I tell people that we're going to try to tackle your downstream problem with diet and medications that I'll mention in a moment. But it is important to try to get upstream as well. And I do think that there may be drivers like Sjogren syndrome or autoimmune things that may drive the mast cells to be overactive. I have no evidence of that, but that's just something I think. The other thing that I do think is also important to recognize is that I do think it's a two-way street between mast cells and autonomic pathways, in that I try to stabilize both at the same time. So, a lot of mast cell symptoms occur when the autonomic system is unstable. And so you want to try to stabilize the autonomic nervous system as best as you can, and that'll help mast cells. But anyway, diet is super important for many people. So the so-called low histamine diet, you can certainly consider. To me, what I hear about over and over is gluten, dairy, garlic, spicy foods, and then really paying attention to high histamine releasing foods that may give people troubles. And then I get really aggressive pharmacologically with antihistamines, typically two antihistamines, sometimes twice a day. I have some people on 3 or 4 antihistamines. So, Allegra, Zyrtec, ketotifen, Benadryl if people tolerate it. And then cromolyn is powerful if you can tolerate it. Xolair, if the insurance companies would let us use it, can be helpful, but it's hard to get approved approved and I guess reimbursed in mast cell problems.
Are there certain autoimmune diseases that tend to overlap with Sjogren's?
Yeah, that's a great question. I guess I probably should have mentioned it on a slide, but there's primary Sjogren's and secondary Sjogren's, and primary Sjogren's is Sjogren's where this is the primary autoimmune thing that's going on. There is secondary Sjogren's where Sjogren's is occurring in conjunction with something like rheumatoid arthritis or another autoimmune condition. But I would say the most common autoimmune condition that I see accompanying Sjogren's is Hashimoto's. Celiac is also not uncommon in my experience. And I'm not quite certain what the story is with the antiphospholipid antibodies and in patients who clearly have Sjogren's with, say one antiphospholipid antibody or lupus anticoagulant. I'm not honestly sure what to make of that.
Here's a good question. Since we talked about the minor salivary gland biopsy so much, someone's asking if you have positive blood work for Sjogren's, do you still need to get the lip biopsy? And if not, how much should the blood work be positive?
Yeah, so we don't, as part of our practice, do a minor salivary gland biopsy if the blood work is abnormal. If a person has typical dry eyes and dry mouth and a condition that would be compatible with Sjogren's and has abnormal laboratory studies, from a clinical standpoint, I don't need anything more to make that diagnosis. Now, if you're talking about getting into a clinical trial, one would need some other objective measure, which could be an objective measure of ocular dryness or of salivary dryness. So, one could have a Schirmer's test or something like that. But from a clinical standpoint, if you're not in a clinical trial, in my opinion, you do not need that.
Okay. And here's probably, I think we should maybe make this our last official question. Any advice on how to convince an insurance company to approve IVIG?
Be tough. Have nurses that go to battle for patients. That's how, quite honestly, we've been able to get it approved, usually. We also have, we have the literature well outlined. And, you need to, strongly advocate for it. But, obviously we need more research. We need clinical trial data in this area, and that will sort of, I think, provide us with the evidence that we need to be able to use this. But absent that, I think you just really need to stick with it and have hopefully a team that can advocate and write letters and talk to the quote unquote peer reviewers who we have to deal with.
Something that I've actually wanted to do with Dysautonomia International is to create sort of like a database or a list where people could download successful sample appeal letters. And so a lot of times the appeals are handled by a phone call, from the doctor's office to the insurance company, but sometimes it rises to the level of needing letters. And I think that if we made letters available for successful appeals, that even though each appeal would have to be individualized to the patient, I think that might help be a good resource. And there was an organization that used to do this called Advocacy for Patients with Chronic Illness. And it was run by Jennifer Jaff. And she was an attorney who had Crohn's disease and sort of decided to dedicate her life to helping patients with insurance appeals and other legal chronic illness matters. Unfortunately, she passed away from complications of her Crohn's a few years ago, and the nonprofit website isn't up anymore, but they had a great database of IVIG appeals. She actually helped me when I appealed for my own IVIG. So I kind of feel like I want to pass that on. So if anyone listening has had a successful IVIG appeal in writing, we would love a copy of your sample appeal letter, with your personal identifying info blacked out or removed. So we could maybe make that available to other patients through our website and the social media pages. So thank you so much, Dr. Goodman. This is really great. I know that this is going to go on our Autonomic Disorders video library, and a lot of people are going to check it out after this evening. Before we wrap up, I just want to let everyone know that Dr. Goodman and many other awesome doctors are going to be lecturing at our conference in Nashville, June 22nd to 24th weekend. It's our 6th annual conference, and we're really excited about it. There's early bird pricing available on conference registrations until May 10th. We also have a May 12th Dysautonomia Patient Education Day with Dr. Freeman and Dr. Raj at Beth Israel Deaconess Medical Center in Boston. And you can find that on our Facebook page. You can find the links to register for that. And then also next month's webinar will be, I think it's May 30th. It's a webinar on sleep dysfunction in POTS with Dr. Miglis from Stanford's Autonomic Lab. So that's a wrap for the evening. Thanks so much, Dr. Goodman, and we'll see you in June.
Thank you very much. Good night.
Good night.